And everyone, it's 5 o'clock. So we are going to get started today. I'm Dr. Michael Dreller. I'm filling in for Dr. Annie Benzie for hosting this afternoon's webinar. Um, this evening we have an excellent discussion on the surgical disease of marginal ulcers, an excellent multidisciplinary topic not only affecting our bariatric surgery patient population, but obviously any patient with a gastrojejunostomy that we may encounter. Our moderator today is Dr. Jessica Zaman. Dr. Zaman is the Chief of Bariatric Surgery at Albany Medical Center. She also serves there as the Program Director for the General Surgery Residency Program and as the Associate Program Director for the Bariatric Surgery Fellowship. Dr. Zaman graduated from medical school at the University of Oklahoma and then completed her residency training at Robert Wood Johnson Rutgers and then fellowship in minimally invasive surgery and bariatrics at the University of Wisconsin. She's very academically accomplished with numerous awards and publications in both bariatric surgery and surgical education. Her practice today mostly consists of robotic surgery and bariatrics, foregut, complex abdominal wall reconstruction, and traditional general surgery. Our presenting fellow today is Dr. John Bartola, who received his medical degree from Ross University School of Medicine. He then went on to complete his general surgery residency at Brooklyn Hospital Center in New York City. Afterwards, went on to complete a Mastery in General Surgery Fellowship and is currently the Complex GI Surgery Fellow at Penn Medicine Princeton Medical Center. So I will turn the slide deck over to you two.
Thank you very much, Dr. Girola. Anybody have any other introductory remarks before we get started?
Thank you for the introduction.
Perfect. All right. Thank you very much and welcome everybody. All right. So my name is Dr. John Bartolotta. I'm the Complex GI Surgery Fellow at Penn Medicine Princeton Medical Center. And today's topic will be on marginal ulcers, particularly in their management, particularly in the Roux-en-Y gastric bypass patient. In terms of an outline, and reversal of Roux-en-Y gastric bypass, as well as some studies and case reports of complex management of marginal ulcers. And particularly, we'll end with the case that I had earlier this year that inspired me ultimately to choose this topic for the Grand Rounds presentation. You can see if you agree or disagree with our ultimate management. All right. So pathogenesis and the cut and dry part of it. Definition: marginal ulcer, peptic ulcers, simply occurring at the gastrojejunal anastomosis, typically post Roux-en-Y gastric bypass, usually on the small bowel side, simply because it's not typically used to receiving that level of acidity as it would be following a gastrojejunal anastomosis. And many etiologic and anatomic and physiologic factors, both iatrogenic in nature, beginning with exposed staple lines, particularly in the setting of circular staple anastomoses or linear stapled anastomoses, and we'll get into that discussion of stapled versus hand sewn anastomoses, or just tension at the anastomosis site. Most of these, in the laparoscopic and robotic era, a lot of these gastric bypasses are being done in an anti-colic, anti-gastric fashion, or just a large gastric pouch, typically go with 30 cc's, is the standard that we aim for in performing the gastric bypass, or if there's any kind of foreign body at the anastomosis, any kind of retained surgical material, and as well as physiologic factors, patient-related factors. It could be just simply acid exposure due to incomplete gastric pouch drainage, or if your BP limb is too short, alkaline bile reflux. In terms of the iatrogenic factors, yes, as we mentioned, technical issues during surgery, such as tight sutures or non-absorbable sutures that stick around, or staples. But primarily these lifestyle and patient factors, we do try to weed these out before performing an index bariatric operation on these patients, primarily smoking and NSAID use, and primarily because both of these decrease blood flow to the GI mucosa, not just the stomach, and lead to mucosal cell death, inhibit the cell renewal and turnover of this rapidly proliferating area of our cells, and interfering with the mucosal immune system. Paper by Dietrich showed that 4.6-fold higher risk as smoking as a significant predictor of the development of marginal ulcers. And obviously, these patients should be counseled on smoking cessation and given resources to do so before offering them bariatric surgery. And several studies have demonstrated that short-term use, even low doses of NSAIDs and aspirin, may not increase the risk, but higher doses, chronic use do. Obviously, this needs to be counseled. Obviously, we always tell our bariatric patients to avoid NSAIDs after surgery, but typically, patients who are on low dose, maybe aspirin for cardio prevention or, for medical conditions, we do at least recommend to combine that with PPIs, as well as Helicobacter pylori infection. I have a slide on that in the future, or as any poor adherence to dietary recommendations. And diabetes was also found not to be as strong of a patient-related predictor of marginal ulcer, but still a 23% increase in the risk, as opposed to a 4.6-fold higher increased risk with smoking. As well as nutritional deficiencies, which can also predispose you to reduced gastric mucosal protection, such as zinc and vitamin Bs. These pathophysiology obviously is going to relate to the imbalance between protective and damaging factors at your anastomosis to protect the mucosa just distal to your GJ anastomosis, leading to reduced blood flow or ischemia or tension. That chronic inflammation is going to lead to ulceration, which is very sensitive, as we know, to gastric acid. And then although the pouch doesn't typically produce that much acid, in some patients that quantity is sufficient to produce an ulcer. The most common presentation of these patients is going to be upper abdominal pain, progressive intolerance of solid food as they advance their diet post-bariatric surgery. Others are going to get, just a painless occult rectal bleeding with some, potential maroon-colored stool or, hematemesis. Other ulcers that are related to bleeding can require hospitalization and occasionally require urgent revisional surgery. Usually it's not urgent, however, unless transfusion is a major consideration. In terms of H. pylori, this is obviously known to cause a major part in the development of any kind of gastric and almost pathognomonic for duodenal ulceration, particularly gastric malignant lesions. I know one of the moderators did ask about prevalence of finding malignancy within these ulcers, of marginal ulcers. In my literature review on that topic, I found that finding malignancy in marginal ulcers was exceedingly rare, significantly less than 1% of marginal ulcers. However, the exact role of H. pylori in post-gastric bypass ulcers and pathogenesis, they say some literature says remains unclear, but likely due to the same mechanisms that it causes ulcers outside the setting of gastric bypasses, creating this state of chronic inflammation, progressing from gastritis to metaplasia and to ulceration. One study by Baran found an odds ratio of 4.97 for H. pylori for the development of marginal ulcer post-gastric bypass, which was its most causative factor that they looked at. For comparison's sake, the odds ratios for smoking were 2.5, and the odds ratio for diabetes mellitus was 1.8. They also found, all these other various patient-related factors: age, BMI, female gender, sleep apnea, hypertension, and alcohol, not necessarily found to be statistically significant predictors of marginal ulceration. And as we do, all these patients should be screened before bariatric surgery. This may, endoscopy, preoperative endoscopy may vary by institution. At least at our institution, it is universal. And the gold standard remains histologic sample. We will do random stomach biopsies, rule out H. pylori in all of our preoperative bariatric patients. And obviously, we'll treat them with triple or quadruple therapy before proceeding to bariatric surgery. In terms of hand-sewn versus linear stapled gastrojejunal anastomosis, I'm going to get through this slide and then I'm going to open it up for some discussion among the panel. There is some literature demonstrating that hand-sewn may have a lower incidence of marginal ulcers due to the hypothesized reduced foreign material. Obviously, the suture would be absorbable compared to permanent staples at the anastomotic site. And overall, the hand-sewn anastomosis, we're doing this primarily with the omega loop technique with the Da Vinci, but with less tension at the suture line. And staples, can create localized ischemia along the staple line, which can cause tissue damage and can contribute to ulcer formation. It's hypothesized as well that may have better blood supply along that tissue at the anastomosis with hand sewn to allow for it, and you can be more precise with your placement of your sutures and preserve that tissue flow to reduce ischemic injury, as well as potentially reducing inflammatory response by having less permanent foreign material along the staple line, as well as just overall cost effectiveness, despite the increase in OR time. Did any of the panel have any strong preferences or the way that you do your gastric bypasses or strong opinions thereof?
I know I can chime in. I was trained doing circular staple anastomoses, and when I came into my practice, that was generally how my partners also did it. But we made the transition. But that also corresponded with me doing more robotic surgery of doing hand sewn, because with the robot, especially when you have trainees, it's much easier to teach somebody and to do a hand-sewn anastomosis, but that's my preference. I would say anecdotally, I have noticed an improvement in at least a short-term rate of marginal ulceration, but yeah, I mean, we have not been doing it long enough at our institution to really see a huge shift in the data. But anecdotally, I personally find it better. I don't know what others feel.
And that's the way I am being trained at my program as well.
So we actually do we do GJs primarily for paraesophageals that have a high BMI, so not primary bariatric procedures. And we do kind of usually a combination of linear stapled robotic stapler with a hand sewn closure. Dr. Zaman, like you, I actually, in the old days of open bypass, used to use a circular stapler through the distal stomach and staple, put in your anvil and then staple using a TA 90 stapler, believe it or not, back in the old days, and then use your gastrotomy as a G-tube because there was such a real incidence of leaks back in those days. And it was kind of your decompressive G-tube plus a feeding access should you need it. And I think the circular stapler is a really brilliant device. There was a lot of debate, and I'd kind of like to ask for your opinion about the size of the GJ being important with regard to weight loss. And I kind of wanted to ask you about that because those that use the circular stapler used to feel very strongly that a 25 was critical as opposed to a 29. But what are your thoughts regarding that?
Yeah, I mean, that was one of the biggest reasons I didn't want to change, because yeah, I felt like that was the thing. You knew with the circular staple, like what you were getting. But, and my partner and I both used 25. It's not necessarily for weight loss, but we felt it was more for dumping, because because then we do the revisions for dumping, as well too. And you find those extra couple of millimeters does make a difference. But, I think that, and again, I don't do linear stapler. I know my partners kind of transition just for time purposes, doing like partially the same way, like partially linear, partially hand sewn. I have found that it's more consistent when you hand sew the anastomosis. Like if you do it the same way every time over the bougie, when you scope them, they tend to have like very similar size anastomoses. Whereas I feel like with the circular stapler, sometimes because of the amount of tension on how you passed the like you said, like past the anvil and what angle it took, so it was a much more variability in the amount of tension, I think. So I actually, even though I was scared to let go of that technique, I do feel that actually the way we do our hand sewing, I feel like it is more consistent because it's a much straighter line that you're trying to connect. It's not like depending on how you get the anvil through and all that stuff. It's a little bit more consistent, at least in my own opinion.
Thank you. No, that's really good. I actually think one of the big takeaways here is probably the size of the anastomosis doesn't make that much of a difference. It was shocking to me that, for some people who do Whipples, for example, some people do this humongously long anastomosis, and it doesn't seem like the incidence of dumping seems to make much of a difference. But thank you for bringing up that really important point, because some people do feel very strongly that the dumping risk is very different depending on the size.
Yeah, and that's what I always think about is like, when we do these, like my surgical oncology partners, they don't pay attention to the same, any of the things, like the size of the pouch or anything. And so it's very interesting how in like different patient populations, we focus on different things.
All right. Thank you very much for both of your contributions. Let's keep moving forward. In terms of epidemiology, in terms of how common this actually ends up being, I say the mean incidence is about 4.6% following gastric bypass, according to meta-analyses of about 41 papers on the subject. And that time gap between surgery and ulcer development varies widely. It varied widely, in the literature, it varied from 1 month to 6 years in certain, however, and in certain series, certain studies within that meta-analysis, they found the incidence as low as 1%. Typically, that time frame will be more about 6 to 12 months following the surgery, is what they found most commonly. And some found as early of diagnosis as 14 to 16 days, others as late as 20 years. But 50, it was about half and half whether or not they would consider it within early or late. And they made that definition of within a year. So about half were within a year, about half were greater than a year out. In terms of diagnosis, upper endoscopy is the hallmark of diagnosis. You can also identify any kind of common diseases that can mimic marginal ulcers, such as stricturing, and any kind of patient with a persistent iron deficiency anemia following gastric bypass should prompt this concern, and this workup definitely needs to get scoped. And early diagnosis is certainly paramount to preventing any of the complications, such as bleeding, perforation, and stricture, which is when this gets really dangerous. In terms of the initial approach, most ulcers, patients with bleeding, they can be stabilized and they don't require urgent surgery. This can be treated with anti-ulcer medication, with proton pump inhibitors to suppress gastric acid, in conjunction with QID, 1 gram of sucralfate, to promote mucosal healing. Usually in about 6 to 8 weeks, this will show dramatic reduction in the size and circumferential aspect of the ulcer, and you can rescope them to see the interval healing, as well as obviously any kind of H. pylori eradication therapy if it's positive. And then you should always, this should have been done before bariatric surgery was even offered, to perform smoking cessation, discontinuation of NSAIDs, and making sure that they are a good patient, psychologically, it's going to adhere to their bariatric dietary advancement guidelines. In terms of monitoring and follow-up, they want, again, advocating endoscopic evaluation regularly to confirm the healing. They should have that baseline endoscopic evaluation, not only pre-op from bariatric surgery, but also when symptoms appear, such as the epigastric, nausea, vomiting, or GI bleeding, to confirm the presence of the ulcer, at which point, and H. pylori testing during the initial endoscopy to guide treatment. Obviously, you are always going to be assessing their compliance with medications and lifestyle changes, and that follow-up endoscopy can be performed typically about 6 to 8 weeks after starting the medical therapy of PPIs and sucralfate to assess the healing. And in the literature, length of initial treatment varied from 1 week to 3 years. It's really going to be patient dependent, and depending on what you see on your endoscopy. One study found that the acid suppression therapy for 6 months was able to lower the marginal ulceration rate from 7.3% down to 1.2% in their gastric bypass cohort. And then their healing rates, just through lifestyle changes in medical therapy, is quite effective, ranging in literature from 68 to 100%, with relapse rates up to about 8% have been reported. And another report by Schulman compared, actually took it a step further and compared not just taking PPIs, but how they're taking PPIs via the open capsule approach versus an intact capsule approach. Since this is rather proximally in the GI system, they actually found that open capsule approach significantly reduced their ulcer healing times, where the open capsule PPIs had a median time of 3 months for ulcer healing, as opposed to those receiving intact capsule formulation had a median healing time of approximately 11 months. So that's a very dramatic difference. And that was the first paper that I saw that made that distinction, as well as nutritional support. Do you guys, if you have patients with marginal ulcers following, typically in gastric bypass, do you guys ever make that distinction in terms of, the medical therapy, like how to take your pantoprazole?
Yeah, absolutely. I find that it's rare because most of them have been counseled with us before, but we tell them, to take it first thing in the morning on an empty stomach. And, every once in a while, there'll be one or two patients that has these chronic issues that isn't taking their medication correctly.
Mhm. In terms of surgical management, yes.
Yeah, sorry, John, hold on 1 second. No, I agree with that. I do a lot of anti-reflux surgery in my practice now, and you'd be surprised at how many patients take their PPI incorrectly. They're
Mhm.
taking it with their meals, they're taking it after meals, and that the PPI is completely ineffective when taken that way. It really needs to be taken a half an hour before meals. And sometimes with those patients, the better thing that I've been finding recently is, now switching them over to a different class of antacids. These potassium channel blockers that are now coming to market are, potentially another alternative way of medical management for those folks who have, compliance issues, because not everybody is able to take a medication 30 minutes, 40 minutes before they wake. It's just, not the way that, people's lives are organized all the time.
Mhm. Thank you, Dr. Gerler. In terms of surgical management, getting into the interest, it's a very substantial percentage of patients, they say, which had a wide range of 3 to 33%, had some kind of anatomic abnormality that potentiated the development of an ulcer, such as a large gastric pouch, or bleeding, or some kind of GG fistula or bile reflux, which, when we start thinking about indications for surgery, we're going to start with obviously non-resolution with medical therapy, persistent symptoms, epigastric pain, intolerance, failure to advance diet, or bleeding, as well as the lack of healing with the optimal medical management, which classically has been PPIs and sucralfate. That may be subject to change in the future with new drugs coming online, as well as complications. Perforation is obviously going to be an acute complication. It's going to necessitate usually emergent surgery. Bleeding or strictures that can cause obstructions or fistula formations. These are all going to lead you down a more complicated path, a surgical path, which makes you weigh your surgical options, revision and reversal. There's different types of revision, and we did, presumably these patients were morbidly obese. That's why they got a gastric bypass. So if we reverse them, theoretically they are at risk of regaining a significant percentage of their weight. And so we would like to keep them skinny and as much as we can. And so we try to go towards revision as much as we can, with reversal being saved for a last option. And typically these revisions can vary, and we'll break them down different kinds. Typically this can be done for a localized ulcer without significant anatomical or functional issues. There's various techniques. You can resect the GJ, including the ulcer, with revision of the anastomosis to address any issues related to tension or ischemia. You could resect the GJ and revise and redo the anastomosis in conjunction with an acid-reducing procedure like a vagotomy. I would say newer generations of surgeons aren't as comfortable as the old generation was with vagotomies. In terms of reinforcement of, or just reinforce the GJ with healthy tissue, kind of like a patch repair, basically. But this is going to aim to correct the different factors, such as reducing acid production through the vagotomy, or fixing mucosal disruption or ischemia, or the gastric pouch acidity by making it smaller, and revising the anastomosis that way. Most surgeons would recommend removing the ulcerated GJ and restoring the GI integrity through a hand-sewn or stapled reanastomosis for those refractory or ischemic ulcers. And some may even require resection of the entire pouch and an esophagojejunostomy if the pouch is already small, or if there's already a gastric fistula present. In terms of reversal, indications, severe complications, intractable symptoms, patients whose lifestyles factors have been unable to be corrected despite myriad counseling. And we'll see an example of a patient of mine that would apply to at the end of the presentation. And the technique of reversal is going to be, the restoration of the normal gastric anatomy, reconnecting the pouch to the remnant via a gastric anastomosis, and usually with resection of the root limb, because that's usually where the ulcer is. In terms of postoperative considerations, always, especially in a bariatric population, nutritional monitoring and support. There should always be routine screening for deficiencies. Our institution screens every 3 months for the first year, particularly with B12, iron, and zinc. All have roles in immune health and mediation. And long-term surveillance for recurrence of complications, particularly the endoscopy with refractory or recurrent ulcers, those who have undergone already surgical revision of their anastomosis. And you can do this with annual or biennial endoscopies in these high-risk patients, or potentially even more frequent with ongoing or even more severe complications. Patient education and multidisciplinary care between not just bariatric surgeons, but also involving gastroenterologists and dietitians as well, the entire bariatric and surgical teams. In terms of the techniques for managing these, we're keeping on the trend of revisions rather than reversals. Like we said, with revision of the gastrojejunostomy, if this ulcer just isn't healing, with several weeks to months of PPI and sucralfate therapy, and as well as ulcers that are caused by iatrogenic factors, factors related to the surgery, tension on the anastomosis, ischemia of the anastomosis, or any kind of exposed staple lines you may see during your endoscopy, would prompt a revision of the gastrojejunostomy. Hopefully, the new one is not under tension, not subjected to any kind of ischemic conditions that would predispose the patient to developing a marginal ulceration. In terms of preparing the patient, usually, obviously, this is minimally invasive surgery, laparoscopic or robotic approach, based on surgeon expertise in their anatomy. They're going to want you to have to mobilize the gastric pouch and the roux limb. There may be a great deal of inflammation as a result of the ulcer, which may make this more difficult. Obviously, revisional surgery is always more difficult than index surgery, but a hallmark of the surgery is obviously going to be resection of the ulcerated anastomosis, excising the ulcerated area, and removing any ischemic tissue or exposed staples, any foreign bodies, and then reconstruct it with well-perfused tissue, the best tissue that you can. Absorbable sutures, reducing any kind of foreign body reactions, with an potential reinforcement of a vascularized tissue flap, such as omentum or jejunal serosa. And any post-surgical modifications, you're going to want to make sure that you have the proper size of gastric pouch, aim for 30 cc's when you're redoing it, because you really don't want to have to redo it again. And then in one report as well, 10 patients underwent subtotal gastrectomy, and 1 underwent total gastrectomy with an EJ anastomosis, all resulting in a 100% resolution rate with no recurrence. That was in one report. So that was in a little more severe presentation. Other techniques would be bile diversion, or for lengthening the roux limb, in the case of any ulcers that were caused by bile reflux into the gastric pouch. The roux limb, in this case, if you've identified bile reflux as the source of this, then you can lengthen your roux limb to 150 to 200 centimeters to divert bile further from the gastric pouch. And then you may also need to reconstruct the JJ as well without any tension or alignment. And then lastly, there is an option as well for reversal of the gastric bypass. In the event of severe or intractable ulcers that have been unresponsive to revision surgeries, you may have already tried to revise it, but it continues to come back and has failed multiple courses of medical therapy, or if there's life-threatening complications in the past, patients have had perforations that have had to get patched emergently, and other solutions have failed. So your last-ditch option, or patients that are unable to quit smoking, or other significant complications like hypoglycemia or malnutrition after gastric bypass. In terms of the patient population that has undergone reversal, according to one study, 30 to 40% said they still experienced some symptoms after reversal, but their article did not detail whether or not they resected the roux limb or not in their reversal. In terms of technique, you're going to dissect the gastrogaginostomy. You're going to restore normal gastric anatomy, reconnecting the gastric pouch to the remnant stomach, and plus or minus resection of the roux limb. I would say, in your experience, in your practice, if you're reversing a gastric bypass patient for marginal ulcer, would you resect the roux limb as well?
I would say the problem is typically when there is a marginal ulcer and it's refractory, in my experience, unfortunately, there's some like it often ends up being a compliance problem,
Mhm.
and so to me, I feel like that's kind of where you're stuck between a rock and a hard place. I actually have a patient right now that I'm thinking about reversing. I would, I actually haven't had to reverse anyone yet, but for her, I would take out the Rulen because they just tend to get a lot of we used to call it roostasis syndrome, but bacterial overgrowth.
Mhm.
So I would be worried about that. But typically, oftentimes the patients have chronic pain or some other type of condition. And then when you reconnect it, there's an element of gastroparesis. And so they tend to have to be very strict with their diet and still have some like it's not going to perfect functionally because you've disrupted the nervous like system. So typically that's something that again it is a tool to have in the back of your like pocket, but you have to recognize that sometimes the people who have these recurrent issues like sometimes it's a medical issue, like if they have like some sort of chronic arthritis or like those tend to be the more difficult patients, but yeah, they're not going to be perfect afterwards, and they need to understand that.
Mhm.
So, Dr. Saman, do you resect the rulum or reconnect
Yeah,
continuously?
if it's somebody that's overweight, still, it depends. If it's somebody that has chronic malnutrition, then I may reconnect it. But otherwise, typically, if they're normal body habitus, they're not suffering from like cachexia or anything like that from the ulcer, then I would just resect the rulum. So it does seem kind of like a waste, but it decreases the risk of having a problem at another anastomosis. So most bariatric surgeons would just tend to resect the rulum. But again, it really depends on the patient.
So I think just to bring up a couple of teaching points over here, because again, being elderly these days, I just turned 60. I actually took care of some patients in the 80s and 90s who had JI bypasses. And so you effectively have a disconnected rulum on steroids, basically, because it's hanging out there. And so these patients did get profound bacterial overgrowth. And so when you're taking that down or reversing that, the first thing to do is to plug a J tube into the disconnected rulum and feed it to try to get rid of what's called D-lactate because they don't produce L-lactate, which is what you measure. And so this was, always terrifying to me because they develop a profound lactic acidosis once you reconnect that limb. And so it's really interesting because, as Dr. Zaman said, I think it's better to get rid of it. Sometimes I'll be pleasantly surprised because we'll have a bile duct injury or something in somebody that had had a reversal, and there's this limb hanging out there that I can then just, plug into the bile duct. But sometimes people will just leave it kind of hanging out in the breeze, and it's a little disconcerting because it's hard to know kind of, what that's doing, what kind of effect that's having on gut flora, etc. I personally find the reversal of the bypasses to be one of the most unsatisfying operations ever because you do a gastrogastrostomy, right, most of the time, and it just never works as well. Like Dr. Zaman said, it's just one of these things where that stomach is never quite as functional. And I don't know, Dr. Zaman, is this because you think that, there are two ways to divide the pouch, right? Perigastric or pars flaccida. If you do a pars flaccida, division, you could be taking the vagus, right, along the lesser curvature. Do you think that a lot of these patients have inadvertent vagotomies by including the lesser curvature vagus at the time?
Yeah, absolutely. And then, like I said, it's also a combination of the patient population and also like the previous surgeries. Oftentimes, I'm not like I've totally been there when you go back to the OR and you randomly see a rulum hanging out. It's the most disconcerting thing. It's very, and I'm like, I wonder if a lot of these symptoms are from bacterial overgrowth. But yeah, no, I definitely do feel like there's an element of a vagotomy, and then also it's just the patient factors as well too. If they're having problems, they're usually doing something that that to sabotage themselves.
Do you routinely include the vessels when you're stapling across your pouch, or do you stay perigastric when you're dividing your pouch?
I stay perigastric. It's a little
Yeah, me
bit
too.
challenging again because like we're working with fellows and it's a little bit
It's
a little bit
bloody.
harder.
It's
Yeah,
bloody.
to do, especially with the robot, you just can't get the right angle with like because we have an assistant also and it's just hard to get the right angle and the right traction, but we try to stay perigastric for that reason.
Yeah. Yeah. No, thank you very much, because I think that's a really important point, and it maintains a little bit of that ascending blood supply to the pouch too. So you've got a little something something going on.
Yeah, I'm always planning for future disasters. And then the other thing I wanted to say is another thing is like in terms of the resections too, a lot of times when you do like from the previous slide, if you do an EJ, which I've had to do, that's if a patient's in a really bad shape, they keep getting perforations or whatever. But people are also never happy with that because it's very they're guaranteed never to gain a substantial amount of weight. But they're always very unsatisfied with the way that they can eat because they really do have to be very, very compliant with how they eat. It's very, very small meals frequently. So, sometimes like that also is a lot of counseling for the patient. So I always make sure that I confirm like I'm going to have a good amount of gastric pouch left when I go back to do a revision because a couple of patients that I've had to do an EJ on are really not satisfied post-op.
And you never know when you need that distal remnant for an esophagectomy, right, Dr. Girola?
Oh yeah. It, I'm just a question to kind of backtrack, very slightly. I mean, a lot of these patients, like you guys are saying, are, there's some behavioral component. And smoking is obviously a major risk factor. So what do you say to that patient who comes to your office interested in a primary bariatric operation, who is a smoker, who can't get off tobacco? And
Oh,
is
they
not
just
maybe appropriate for a sleeve. They have a hiatal hernia or they have really bad reflux or something else. Do you
I won't
tolerate a
operate
certain
on
amount
them.
of tobacco intake, or is it, I'm sorry, but no?
Yeah, I'm sorry, but no, I have a patient who has like horrible chronic marginal ulcers and has like a because she has like a GG fistula too, but she's a smoker. And so I'm like if she wants this revision and even though she is quite symptomatic, I'm not going to give it to her unless she stops smoking. Because like otherwise like it's just going to recur. So I try not to, and we actually check a nicotine test pre-op for all of our patients as well too for people who had a history of smoking. There are some people though that there is tobacco recidivism, and that I can't help. But yeah, I'm at that. It's just not worth it. Um, the quality of your life can be quite horrible.
Thank you very much, Dr. Zimmer. Okay. And in terms of emergency, management, for perforation repair, again, we're going to treat this just like any other perforated peptic ulcer, with, closure with absorbable sutures, and, mental patch repair. Some would say you could potentially revise the gastric ulcer in the emergent setting, but that's going to depend on, the stability of the patient, and usually less is more in emergent situations. If the perforation was caused by an ischemic ulcer, a large pouch, or an occult GG fistula, the root problem may still exist. You've simply patched the problem, not definitively resolved it, but at least you may have gotten them out of the woods enough to consider revision in the future in the elective setting. If the GJ, was ischemic due to tension, and that led to the perforation. And in terms of management of bleeding ulcers, you can attempt endoscopic control first with hemostatic clips and coagulation, and leave surgical resection, if endoscopy fails. That's a little more uncommon though. And then reinforce the area with sutures or tissue patches to prevent the recurrence. In terms of key considerations, you're minimizing your recurrence risk, whatever decision you make, and addressing by addressing patient factors like smoking, NSAID use, nutritional deficiencies, and intraoperatively always assessing your tissue quality, focusing on well-vascularized tissue to reduce your ischemia-related ulceration, and then post-surgical monitoring with regular endoscopic evaluations, documenting successful healing, or to diagnose recalcitrant ulcers, and typically around 8 to 12 weeks after treatment or surgical intervention. In terms of, I'm going to get into some studies and some reports of some certain complex cases. We'll end with my own. Any questions about marginal ulcers in general at this point that we haven't gone over?
You know, I think one thing to keep in mind, and maybe Dr. Zaman can comment on this, is if you've got a posterior ulcer and it's bleeding substantially, think about a fistula to the splenic artery. This is something that's kind of disastrous to find in the operating room and is a lot nicer if you embolize it before you go. This is, usually in my experience, it's significant pain, fairly significant bleed, and, you've got this crater ulcer thing. And just wondered, Dr. Zaman, if you want to comment on that.
Yeah, luckily I haven't had that situation yet, but I've had some, when you have like really, which that means it's going to happen to me next week. No, but one thing I would say is those large crater ulcers, like they are actually really hard to control. And they tend to be in people who are alcoholics and cachectic and not healthy because they didn't take care, they didn't seek any care. So I have to say, like, definitely those weren't investigations. So maybe, as Dr. Gerard said, that's something to pay attention to. But also, I personally find them very hard to control endoscopically. So even though I do most of the, my own cases, if that, would happen, but with those, like, sometimes GI has lots of little tricks, like even just being able to visualize because you have so much bleeding. And then, like they have all these little toys that they use to help out with stuff like that. And then I found that in the 1 or 2 bad cases that we had that we really couldn't get because you clip and the ulcer is so bad, everything is fried and macerated, it perforates, like, and then they're not going to survive an operation because they're really sick. But just like just hemostatic agents, like they have this potato starch spray that they use that works really well. So those are not easy cases.
All right. This was one study that looked at revision gastrojejunostomy versus suturing gram patch repair for perforated marginal ulcers, with or without omental patch, post gastric bypass. And of the revision gastrojejunostomy patients, 11.4% experienced ulcer recurrence, so only 11% versus a whopping 41% of the suture gram patch repair patients. So like we said, the gram patch repair, you temporize the situation, you got them out of the woods, but you've not solved the definitive problem. And then only 2.8% of the revision gastrojejunostomy versus 11% of the sutured gram patch repair patients ultimately required a reversal. Suggesting that the revision gastrojejunostomy can lead to a lower likelihood of ulcer recurrence with comparable short-term morbidity suturing methods. Obviously, it's going to depend. We're talking about emergent surgery here, so it's going to depend on the stability of the patient and how they're doing in the operating room in terms of how thoroughly you can address their issue at that time. And then in terms of a mental patch repair, again, on the same topic, they evaluated the effectiveness of a mental patch repair for perforated marginal ulcers following gastric bypass. And then compared to anastomotic revision, they said the mental patch repair had, again, we expected to have shorter OR time. It's a less involved surgery, 101 versus 138 minutes. It's going to depend on the stability of your patient, but they also noted that it had decreased estimated blood loss, which we expect to involve surgery, and a shorter length of stay at that emergent hospitalization. So it is safe, and it is can be safely performed, and there's definitely a role for it as an emergent procedure managing the complications. Can set you up for definitive revision down the line. This is another report of the endoscopic reversal of Roux-en-Y anatomy for marginal ulcer treatment. This was a case where they undertook endoscopic reversal of a gastric bypass anatomy to treat a marginal ulcer after multiple failed surgical anastomotic revisions had failed, and it had recurred 3 times, complicated by malnutrition in the patient, so they don't want to subject the patient to another surgery. This procedure involved restoring the normal anatomy. Obviously, you can't resect the roux limb in this endoscopic reversal, but you can address the ulceration effectively via a luminal opposing metal stent to connect the pouch to the remnant, and a gastric outlet reduction via a TOR to close the gastrojejunectomy, basically. And I have this report actually was kind enough to include a video as well.
A 56-year-old woman who was referred for poor oral intake and malnutrition secondary to recurrent marginal ulcer that failed medical and surgical management. She underwent Roux-en-Y gastric bypass approximately 18 years ago. She had recurrent marginal ulceration for 10 years that was complicated with recurrent perforation and stricture. Status post-surgical revision of gastric jejunostomy twice, but later developed a recurrent ulcer. She's also an active smoker. The treatment options were
so multiple reasons for reversal here, for both complications of recurrent surgery, as well as lifestyle factors patient continued to smoke.
Discussed with the multidisciplinary care team and the patient. Surgical options were limited. The last surgical revision took approximately 3 hours for lysis of adhesions. The decision was made to proceed with an EUS-directed gastrogastric fistula creation with a lumen opposing metal stent, and endoscopic suturing closure of the gastrojejunectomy for a full reversal of Roux-en-Y gastric bypass. This was her marginal ulcer at her jejunum, and this was a retroflex view demonstrating a deep, nearly circumferential ulcer. The first step, we performed a gastrogastric fistula creation with a lumen opposing metal stent. Then, a linear echo endoscope was inserted into the gastric pouch. The remnant stomach was identified by its Ruggie folds under ultrasonography. A 19-gauge EUS needle was advanced to the remnant stomach in parallel to the native anatomy to allow food to go down with gravity, and a contrast was injected to distend the stomach to provide a target for endoscopic ultrasound access. Under fluoroscopy, the remnant stomach was filled with contrast. The distal flank of a 15 by 10 mm lumen opposing metal stent was then deployed under sonographic and fluoroscopic guidance into the remnant stomach. The proximal flank of the lumen opposing metal stent was deployed within the gastric pouch successfully, creating a gastrogastric fistula. A 15 mm through the scope balloon dilator was passed through the lumen of the lumen opposing metal stent, and the tract was dilated to ensure an advocate stent expansion. An endoscope was inserted. The LAMS appeared to be fully expanded. The gastric remnant and duodenum were examined and showed healthy appearing mucosa. The second step, closure of the gastrojejunectomy stoma with endoscopic suturing. Here was the stoma. A high voltage argon plasma coagulation at 50 watts and 1 liter per minute was used to circumferentially ablate the mucosa to stenose the opening. A suturing system was then used. A tissue helix was used to ensure a full thickness acquisition. 2 sutures of figure of 8 pattern were placed to completely defunctionalize the limb. After suturing was completed, we used a cinch catheter to cinch the suture. A tension was applied to the suture until the desired pressure was reached. The cinch was then deployed. A full reversal of Roux-en-Y gastric bypass anatomy was achieved. Contrast was injected into the gastric remnant and was able to enter the gastric remnant with no evidence of leak under fluoroscopy. A post-operative CT scan showed a patent LAMS connecting between the gastric pouch and gastric remnant. At 18-month follow-up, she was able to tolerate normal diet with no abdominal pain or perforation despite continued smoking. She also gained around 8.7 kilograms from 53 kilograms at the procedure to 61.7 kilograms at follow-up. A follow-up endoscopy was performed at 18 months. The marginal ulcer appeared to have improved considerably from nearly circumferential to 1/3 of the size. Endoscopic suturing oversaw of the ulcer bed was successfully performed. The lumen opposing metal stent appeared to be intact.
All right. So that was their method and seemed to work very well for this patient in particular, particularly one that was smoking, malnourished, and had a very BMI approaching underweight. BMI was 19 at the time of that endoscopic reversal. So for many reasons, a patient that you would not want to touch surgically, especially after they had, sounds like had a bear of a time at the last revision. And some of their images as well, their CT and their follow-up repeat endoscopy. But that was a great case. Any questions so far? I'm just going to get into my case, which inspired this. Any comments about that technique? Or has that anybody done or seen the endoscopic reversal in any of their institutions, or really had to even think about going for this?
We've done a couple of the endoscopic GJs, but usually like it's for strictures. So the patients we haven't done a tour, to close the outlet, but that's something to think about. I wonder if maybe that will help because that particular patient is still having some symptoms. So maybe that's something to throw in there. But I think this is a useful adjunct to have.
Definitely a useful adjunct, something that can definitely help you when you're with a very difficult patient and you don't really see a whole lot of other options, and you particularly have ruled out further surgery. In terms of my case, I had a complicated patient. He was a 41-year-old male. He had hypertension, lipidemia. He had a history of Barrett's before his gastric bypass, and morbid obesity, which is why he got a gastric bypass back in 2018, which was complicated by recurrent marginal ulcers impeding his PO intake, as well as anxiety and depression. He also he fell off a scooter. He had a horrible scooter accident in the summer of 2023, which required a hospitalization for 2 months, where he was in the ICU with traumatic brain injury with intraparenchymal hemorrhage, which was further complicated by DVT and PE and recurrent GI bleeds on anticoagulation, requiring mechanical thrombectomy, IVC filter placement, after which he ultimately got a trach and open G tube, with later decannulation and later G tube removal. He also had another admission for rectal bleeding from hemorrhoids. He required IV iron infusions and blood transfusions, and he had marginal ulcers confirmed on his EGDs in July 2023, October 2023, and February 2024, all while on BID Protonics therapy with sucralfate, and his Barrett's had resolved following his gastric bypass. He was a former alcohol drinker. He had quit following his prolonged traumatic brain injury hospitalization, and was an intermittent smoker. His BMI before his gastric bypass 7 years ago was 41. His BMI at the time that we decided ultimately to reverse him was 25. This was his EGD, the last one that he had done before we decided to reverse him. As you can see, the ulceration at that gastrojejunal anastomosis, the root limb otherwise had healthy appearing mucosa. The BP limb wasn't examined, but biopsies were taken. It showed fibrous stromal tissue, ulceration, acute inflammatory exudate, everything you would expect to see at the ulcer. And so due to his non-healing ulcer with maximal medical therapy that had come back 3 times, his persistent abdominal pain, his persistent difficulty eating, his BMI now being down to 25, and given previous substance abuse and difficult compliance, he clearly had not fully recovered from his traumatic brain injury, which definitely impeded his compliance. The decision we felt the best decision to be made was that he would benefit most from Roux-en-Y gastric bypass reversal rather than revision. And so that's what we did back in August. So we did a robotic-assisted laparoscopic reversal of root right gastric bypass, resected the root limb. He had a lot of adhesions to his abdominal wall in the area of his previous G-tube, which had to be taken down. He had a retrocolic, retrogastric GJ, which we had to dissect through in order to resect. And then that chronic marginal ulcer was resected as part of the GJ anastomosis, which required stapling across the gastric remnant to resect entirely and block. And then we were able to do a gastric linear stapled anastomosis between the pouch and the remnant, oversewed that with 2-layer closure, Vicryl and PDS. And then we resected the distal root limb after tracing it through the transverse mesocolic defect, which we closed with 2O PDS. Got good hemostasis, left a drain over the GG anastomosis onto the liver, and removed the GJ specimen and the root limb specimens from the patient. Took about 4 hours. So he ultimately ended up doing well, but the case itself inspired me to kind of look up some of the literature on reversal of gastric bypass, and there was rather kind of a paucity of data on reversal of gastric bypass patients, but the largest single institution study was done by Higa, which was a retrospective review of 48 patients who had laparoscopic reversal of root right gastric bypass in the mid-2010s. Most of them were female, and the indications for reversal, 25 out of the 48, were for marginal ulceration. 12 of whom were malnourished, and 17 of whom also had a coexisting substance abuse. 11 of those 48 reversals just had malnutrition, didn't have marginal ulcers. In another 7, it was just chronic pain and nausea. And in another 5, it was just a reactive hypoglycemia. So in terms of their single center study, they found an overall 30-day complication rate of their reversals of 29%. So 14 out of that 48, including GG anastomotic leaks, sepsis, bleeding requiring transfusions, the 6% rate of bleeding requiring transfusion. And then obviously you're reversing bariatric surgery, weight gain is going to be expected. That increased in all patients, especially those that were deemed severely malnourished. All patients reported resolution of symptoms, which led to the reversal of their gastric bypass, although sadly they did lose 50% of them to follow-up after a year in this study. But because the complication rates are high, reversal, we try to consider it only after salvage attempts have failed. That you could see their complication rates for reversals, 29%, which they noted was comparable to other revisional procedures. But they noted, which is a 9-fold increase in the leak rate of revisional surgery, which was doubling, which also was double the length of stay compared to primary bariatric procedures. And they noted that chronic marginal ulcers were difficult to manage, they can perforate, they can persist. Despite adequate proton pump inhibitor therapy and cessation of smoking and NSAIDs and alcohol. But in some of the studies, 17 to 22% of the patients with marginal ulcers ultimately did require revision of their gastrojejunostomy. And almost half of the patients in this study who ended up getting reversed due to the chronic marginal ulcers had previously undergone surgery for the perforated ulcer. So clearly, they had complications before, which were managed surgically before they got to the step of reversal. And there was a high association with substance abuse, alcohol, tobacco, with low possibility of cessation after multiple attempts. And that factored heavily into their decision to reverse. And then just as expected, how much weight do we expect these patients to gain after reversing them? You just look in the second to the right column of all reversal patients' change in BMI as a function of time. You could see, a year out, their BMI had gone increased by 4. 2 years out, it increased by 4.8. 3 years out, 5.2, and 4 years out, BMI had gone up by 10. Our patient, as of his last visit, his BMI is now 31. From his initially 41 at the time of his gastric bypass 7 years ago, and down to 25 following at the time of his reversal. So
Excellent. Dr. Bartolotta, oh, excellent. We're at question time. We are reaching
You're
the
done.
witching hour.
I'm done. I'm sorry I went a little long.
No. Excellent presentation.
Thank you.
Yeah, great job, great points. Good discussion.
I guess just my one thing is, and I'm not a bariatric surgeon, but to Zaman, it sort of makes me want to cry every time we talk about reversing a gastric bypass. I mean, even when my endoscopist does an edge procedure, I'm just like weeping because, we spend our whole lives trying to prevent a gastric fistula, and then we're actually actively creating one. Can you just help me with the emotional turmoil?
I can't help you because I feel the same way. But what I do tell patients is I wish I had a magic 8 ball that could tell me their trajectory. Because I think the biggest thing is sometimes we do these bypasses in people who don't have that, who shouldn't have them. And I feel like those are the reasons for reversal for me. Like you said, there's like so much like substance abuse. And if you could pick those people up when you saw them in the office, like when they were at their index procedure, like preventing that initial procedure from happening is the best for me. But I have the same issue. Like, it's a tool we use sparingly, but it's sometimes necessary because the patient probably shouldn't have had that operation in the beginning.
And then I think, one of the thing is being in the DFW area, which is such a huge sleeve city, I just would make the plea that, having somebody like Dr. Zaman or, Dr. Balota, your faculty who have a whole array of possible options for a patient is so critical because it's not a one size fits all practice. And just speaking from the other end of the perspective, which is, just to talk about, esophageal cancer and other operations that need to be done, a sleeve burns a lot of bridges down the line. It's easy to think about it as your first stage for whatever, because you could always go sleeve to bypass or sleeve to, D-switch or whatever you want to do. But it also burns a lot of bridges down the line should you need the stomach for anything in the future. Whereas if you've got a bypass, you can still use the remnant stomach for multiple things. Just kind of putting in perspective kind of thing.
Yeah, there is a role for endoscopic sleeve, sometimes.
Yeah,
Yeah, I have that patient now, but anyways.
yeah. Thank you.
Well, thank you so much. I'm glad to have been part of this discussion. Thank you all.
So much. Appreciate all
Dr. Girola, if we could share your screen, Dr. Pollard, and if everyone could go on camera. Dr. Girola, can you do the Annie Benzi picture situation?
Of course, everybody, put on your best hair and makeup. I think Bev is going to take a nice screenshot picture of everybody. So if
Bev, you
everyone
got it?
could put their cameras on, and Bev, whenever you're ready.
Okay, there's very few cameras on at the moment. Hang on one sec.